So happy to
Hi.
Hi, also happy to see us all here. We're about 225 of us. We should be happy about that. Congratulate yourselves. So here I'm going to be welcoming a very special person into our midst. She's a lady as well. She's a physician. She's a gynecologist, oncologist, and her name is Dr. Naana Afua Jumah. She's an obstetrician gynecologist at the Thunder Bay Regional Health Sciences Center, and that is in Northern Ontario. She's also a researcher at the Northern Ontario School of Medicine. In obstetrics, Dr. Jumah's research and clinical practice focuses on Indigenous women's health and substance use in pregnancy in Northwestern Ontario. In gynecology, Dr. Jumah focuses on cervical screening and colposcopy. So if you have any questions about that, definitely you want to reach out. She serves as the cervical screening and colposcopy lead for Northwest Ontario with Cancer Care Ontario, and she is the Director of Education for the Society of Canadian Colposcopies. Through a series of integrated research studies, Dr. Jumah seeks to determine how to organize a model of care that addresses the obstetric and gynecologic needs of women living in rural and remote areas in order to improve their health outcomes. She holds a bachelor's degree in chemical engineering from the University of Toronto, and she also has a Doctor of Philosophy in medical engineering from the University of Oxford, which she completed as a Rhodes Scholar. Following her doctorate, she graduated from Harvard Medical School and then completed her residency in obstetrics and gynecology with a specialization in addiction medicine at the University of Toronto. Dr. Jumah is the Director of Academics at the Thunder Bay Regional Health Sciences Center, and she's also the incoming chair of the Physician Services Inc. Foundation. Welcome. With all these wonderful accolades, I want us to welcome Dr. Naana Jumah. If you have access to your emojis, just, thumbs up, balloons, hand claps, everything. Welcome, Dr. Naana Jumah. Dr. Jumah, you're welcome into our midst.
You're welcome.
Thank you so much, everyone. Are you able to see my screen?
Yeah.
Okay, excellent. I'm so delighted to be at such a wonderful gathering. I hope you will find this presentation helpful, and there should be time at the end for questions. So I'm just going to get right into it. I think this is a really important topic for us as women, because it's actually fibroids are something that really affect African women, much more so than other women. And I will talk about that as I go through the presentation. So I'm going to talk just about what fibroids are. I'm sure we've all had experience with them ourselves or with family members who've had them. How fibroids can affect us as women, how fibroids affect fertility, which was the talk that I was asked to give, how they can affect pregnancy, labor, and how we can manage them to preserve our fertility. So first, I'll start with what are fibroids. They're benign smooth muscle tumors, and they grow based on hormones. So what that means is that they are not cancer. They will never, ever become cancer. They just start off as balls of muscle. And then our hormones, particularly progesterone, causes them to grow as we age. So this is a picture here of a uterus, and this is the cervix down here in the vagina. And this is just showing different locations of the fibroids. They can grow in the wall of the uterus, like these ones.
Teaching us about fibroids.
Those are called intramural fibroids. They can grow on the outside edge of the uterus. That's called a subserosal fibroid. They can grow hanging off the edge of the uterus, which is called a pedunculated subserosal fibroid. And they can grow touching the lining of the uterus, a submucosal fibroid, or hanging off the lining of the uterus, a pedunculated submucosal fibroid. And this may seem very technical, but this is actually really important to understanding how fibroids affect our fertility and how they affect us overall. Fibroids are very, very common among Caucasian women. By the age of 35, about 30% have fibroids, and by the age of 70, about 60% have fibroids. But amongst African women at the age of 35, almost half of us have fibroids, and by the age of 70, almost 80% of us have fibroids. So almost all African women have fibroids. If you get your period early, you're at higher risk for having them. If you've had no children, if you have a history of infertility, or if you started using the birth control pill at an early age, and that might not be for birth control. Sometimes we use the birth control pill for heavy bleeding or for irregular periods. So if you've used it early, that also increases your risk. You have a lower risk of having fibroids if you've recently given birth or if you had your first child before the age of 25. So how do we diagnose fibroids? That can be on exam when a doctor, a gynecologist, or your family doctor, nurse practitioner feels the uterus. Sometimes it can feel enlarged, it can move around, you can feel irregular lumps and bumps. We can do it with radiology, so using ultrasound, MRI, or surgery to locate fibroids and confirm that they exist. We don't recommend, however, that you routinely monitor for fibroids. We only recommend that you look or do an exam if you're having difficulties. So if you were to do an ultrasound, this is what you would see. This is the uterus here, and you can see this little round area off to the side. That's what a fibroid looks like on ultrasound. The ultrasound can be done either through your belly or through the vagina. If we add a little of saline into the uterus, you can see that that's a black fluid there. It's much easier to see fibroids here, especially fibroids that touch the lining of the uterus. You can also do an MRI. And this is the spine here. This is the uterus here. That's the front wall of the belly. That's the bladder there. And this is a large fibroid here. We can look at MRIs with different colors, and you can see this is the uterus here again. This is the bladder here. That's the spine there. And these little black circles are all the fibroids in the uterus, and that stripe there is the lining of the uterus. MRI is really helpful in determining if something is a fibroid or adenomyosis, which is another condition that can happen in the uterus as we age. The last way we can diagnose fibroids, especially those submucosal fibroids, the ones that touch the lining of the uterus, is to do surgery where we put a camera in through the cervix and look inside the uterus. And this is what a fibroid would look like. It's just a little ball of muscle that's sitting inside the uterus. So those are the ways that we can diagnose fibroids, either on exam, ultrasound, saline infusion ultrasound, MRI, or hysteroscopy. So how do fibroids affect us as women? Well, there's really 3 B's. That's how I like to think about it and make it easy to understand and remember in my mind the effects. So bleeding. That's probably the most common symptom of fibroids, and oftentimes that's heavy menstrual bleeding, but you can also have bleeding between periods, bleeding after intercourse, and that can be caused by fibroids. Another common symptom are bulk symptoms. So that means your uterus is getting bigger because of all those fibroids. You might notice increased pressure or increased swelling of your belly. Sometimes it makes it difficult for women to urinate. Sometimes it makes it difficult for women to have bowel movements. Sometimes women can have pain because of that. And sometimes you can have pain or discomfort with intercourse as a result of all the fibroids there. And finally, fertility, which I say is baby to get the 3 B's. So it can cause infertility for some women, or it can reduce your fertility for other women. And so those are the 3 main impacts of fibroids: bleeding, bulk symptoms, and infertility. So in terms of bleeding, which fibroids affect bleeding most? And I'm going to go through this so that if you're meeting with your primary care provider, you're meeting with a gynecologist, this will just sort of help you understand all of the things they may tell you during the course of that appointment. So the types of fibroids that affect bleeding most are the submucosal fibroids. The type of fibroids that impact you most for those bulk symptoms are the pedunculated submucosal fibroids, the intramural fibroids, and the subserosal fibroids. And now we'll talk specifically about fertility because that's the main message for this talk in terms of fibroids and fertility. And I'll go through and show which fibroids affect fertility most in this section. So fibroids account for about 2 to 3% of cases of infertility overall. And the way that they do that is that they change the shape of the uterine cavity, as you saw in those pictures. They can make the new pregnancy difficult to implant in the lining of the uterus, and that's necessary for pregnancy to continue. So that means it's more likely that you'd have a miscarriage. They can cause the uterus to contract in an abnormal way, and that can impair an early pregnancy. They can cause inflammation in the lining of the uterus. They can change the blood supply to the placenta, and again, that increases the risk of having a miscarriage. They can cause the placenta to adhere to the lining of the uterus in an abnormal way, and that can increase risks for pregnancy complications. And they change the hormones that are in the lining of the uterus, and that can also impact the ability to continue a pregnancy and increase the risk for miscarriage. So do all fibroids have the same effect on fertility? The answer is absolutely not. So if we look at this picture of the uterus again and the locations of all the fibroids that affect fertility most, I'm going to go through them with a stop sign so you can sort of see. So really, subserosal fibroids and pedunculated subserosal fibroids have very little impact on fertility. And I've got this analogy here of the stoplight. So green are not bad, yellow we're concerned, and red are the ones that are really concerning. So the subserosal and pedunculated fibroids do not really have any impact on fertility. The intramural fibroids can sometimes have an impact on fertility, but are less likely to. It's really the pedunculated submucosal fibroids and the submucosal fibroids. So anything that touches the lining of the uterus can really have a strong impact on pregnancy. And typically, if a woman is trying to conceive and we see that she has fibroids in these locations and she hasn't been able to conceive, we recommend removing those fibroids to increase the chance that she would be able to get pregnant. So submucosal fibroids, those fibroids that are touching the lining of the uterus, they really decrease the rate of implantation. They reduce the rate of pregnancy carrying to term, and they really significantly increase the rate of miscarriage in that first trimester of pregnancy. Intramural fibroids have less of an impact. So those are the fibroids in the wall of the uterus. The fibroids touching the outside lining of the uterus, far away from that lining of the uterus, really have no impact on pregnancy whatsoever. So does removing fibroids or myomectomy, that's what we call removing fibroids, does removing fibroids improve fertility? So for those submucosal fibroids, myomectomy does improve fertility. For intramural fibroids, so fibroids in the wall of the uterus, removing them it may benefit, it may not, it's not clear. For the subserosal fibroids, so those fibroids on the outside lining of the uterus, that are nowhere near the inside lining of the uterus, there's no impact on myomectomy on fertility. And in fact, removing those fibroids can cause other pregnancy complications. So if you were to remove these fibroids, it may mean that in the future you might need a C-section when otherwise you could have delivered vaginally. So typically, if you're able to get pregnant and you have subserosal fibroids and they're not causing you other symptoms, we just say leave them in place. So do fibroids affect pregnancy? So you've been able to get pregnant. Now, what's the impact of those fibroids that you have there? So overall, if you have fibroids, they do impact pregnancy. And that impact is definitely higher for women of African origin than Caucasian women. And you're more likely to have a miscarriage or preterm delivery if you have fibroids. And you can see for African American women, that rate is about 18% compared to Caucasian women. Fibroids also can change size and grow during pregnancy. They're most likely to grow in that first trimester of pregnancy, and they're most likely to grow if they're already bigger than 5 centimeters. I've been chatting about the impact of fibroids on miscarriage. If you are pregnant and you have fibroids versus you have no fibroids, your rate of miscarriage is about 14% compared to about 7%. So you're twice as likely to have a miscarriage if you have fibroids than if you don't. And if you have lots of fibroids versus just one fibroid, women who have many fibroids, the risk of miscarriage is almost 25% compared to just one fibroid or no fibroids. So the more fibroids you have, particularly if they touch the lining of the uterus, really increases your rate of miscarriage. Sometimes women can experience pain during pregnancy if they have fibroids. And that's because if that fibroid really starts to grow, it can outgrow the blood supply to the fibroid, or it can block its own blood supply. And that causes the fibroid to die a little bit. And as that happens, it causes a lot of inflammation, and that inflammation we feel as pain. This can be very, very significant for women in pregnancy. And oftentimes we do have to admit women to hospital to manage that pain because we don't have good pain medications that we can use at home. The best pain medication to manage this are anti-inflammatory medications like Advil or naproxen. Unfortunately, those aren't safe to use in pregnancy, particularly after the second trimester. So this can be a big issue for women, especially if they have larger fibroids. So if you do have pain with fibroids in pregnancy, it often happens late in the first trimester or early in the second trimester when those fibroids are really growing. Only a small percentage of women who have fibroids will have pain and will need hospitalization because of that. And like I said, the management for that is medications. The best are anti-inflammatory medications or non-steroidal anti-inflammatory medications like Tylenol, Advil, naproxen, indomethacin. But we try not to use those beyond the third trimester, absolutely, and really in a limited way in the second trimester. In very rare cases, we have to remove those fibroids if women are very, very unwell because of a degenerating fibroid in pregnancy. Fibroids can also be responsible for a lot of other complications in pregnancy. So here's a whole list, and I'll go through them one by one. So abruption is when that placenta separates from the lining of the uterus. The risk of that is 3 times higher than if you don't have fibroids. And that's because, as I mentioned earlier on in the pregnancy, oftentimes if there's a fibroid there and the placenta grows over top of the fibroid, that placenta doesn't attach the way that it's supposed to, which is why we see abruption, because if the placenta doesn't attach the way it's supposed to, it may separate from the uterus before it's meant to, and that's called abruption. So if you have fibroids, you're much, much more likely to have that happen. You're more likely to have something called placenta previa, 2 times more likely than women without fibroids. And a placenta previa happens when that placenta covers over the opening to the cervix. And when that happens, you're at increased risk for having bleeding, increased risk of having preterm delivery, and you're at increased risk for having a cesarean section, because that's the only way we can deliver women safely with a placenta previa. PTL means preterm labor. I mentioned this before. Women with fibroids are more likely to deliver early, and you're about 2 times more likely to deliver early compared to a woman without fibroids. And the women at biggest risk for this are women who have many, many fibroids and women who have fibroids touching the lining of the uterus. You're 1.5 times more likely to have intrauterine growth restriction. So what that means is that baby doesn't grow as well as it should. And we see that again in women who have many, many fibroids in their uterus. We also see that if the placenta doesn't attach to the uterus the way that it's supposed to because of submucosal fibroids. Risks for first trimester bleeding or rupture of membranes early in pregnancy, which are these last 2 points, are increased, but much less than these other complications. Do fibroids affect labor? And they do affect us when we're going to deliver. If you have fibroids, you're 4 times more likely to end up having a cesarean section because of that. And that could be because of some of those other complications we talked about, the abruption, placenta previa, babies too small. It can also happen if those fibroids are blocking the path of baby's head to descend into the pelvis, into the vagina to be born normally. Sometimes when women have lots of fibroids, baby can't turn so that it's head down in order to be delivered. It's either breech presentation, so bum down, or sideways. That's called malpresentation. That's 3 times more likely to happen if you have fibroids than if you don't. Labor dystocia means that baby's head isn't able to come down, the cervix isn't able to open to be delivered vaginally. That's 2.5 times more likely if you have fibroids. It's much more likely if you do deliver vaginally or by cesarean section that placenta is going to get stuck. And that's because, like we mentioned earlier, that placenta may not attach to the uterus in the normal way if there are fibroids present. Finally, it's more likely to have a preterm delivery, so deliver before 37 weeks if you have fibroids compared to if you don't. After delivery, you're also much more likely to have complications. Mostly that's due to bleeding, so postpartum hemorrhage, and you're 2 times more likely to have postpartum hemorrhage with fibroids than if you don't have fibroids. And that's because it affects the uterus's ability to contract after delivery. And that contraction of the uterus after birth is what prevents bleeding. With fibroids in the way, the uterus isn't able to contract as effectively, and then you're at increased risk for bleeding. If you're at increased risk for bleeding and we're not able to help that uterus contract with medications, sometimes if we do everything that we can with medications and massage and balloons to make bleeding stop after delivery, sometimes the only thing that we're able to do to save that woman's life is to do a hysterectomy. And so if you have fibroids, you are almost 15 times more likely to end up having a hysterectomy because of bleeding after delivery compared to a woman with no fibroids. So as you can see, there are real risks for women who have fibroids in pregnancy. And it's not just in terms of getting pregnant, but it's during the early part of pregnancy, there are risks during the 2nd and 3rd trimesters, around delivery, and even after delivery, which is why this is such an important topic to talk about, because we know that fibroids affect African women much more than any other group. So how do we manage these fibroids? Well, we can sometimes manage them with medications. The birth control pill oftentimes decreases the amount of bleeding you have with fibroids. It doesn't change the size of the fibroids at all. GnRH agonists are medications that sort of put us into a temporary menopause, that once you stop the medication, your hormones come back and you're not in permanent menopause. Those can decrease bleeding. They also decrease the size of the fibroids while you're using the medication. But once you stop the medication, those fibroids increase in size. Sometimes we use this medication in particular around the time of surgery to shrink fibroids, to reduce complications during surgery. We don't typically use them long term because they have a number of other side effects. Danazol is a androgen, so a testosterone-like medication that decreases the amount of bleeding, decreases fibroid size while you're using it. But once you stop, those fibroids increase again. There are combination medications that are newer on the market, one called Myfembree that's just been recently approved in Canada that decreases bleeding with fibroids, decreases fibroid size, and those fibroids seem to maintain that reduction in size for some time after the medication is stopped, but eventually do increase in size once again. And finally, there's a medication called cyclopropin or tranexamic acid that reduces the amount of bleeding that you have, but doesn't impact fibroid size. So typically when we're talking about fertility, sometimes we use these medications to increase your blood level, to make you more healthy to carry a pregnancy. Sometimes we use them before surgery to reduce the size of fibroids, to reduce the complications in surgery, and to make surgery a little bit easier and recovery from surgery easier. But we don't typically use these as first line to treat women to improve fertility. The mainstay treatment to improve fertility is surgical management. So that can be done by something called an abdominal myomectomy. That's where we make a cut on the belly, either low down by the bikini line, like where you would make an incision for a C-section, or up and down below the belly button. And really the choice of those two incisions depends on the size of the uterus and the location of the fibroids in the uterus. Sometimes the uterus can be quite large. It can be at your belly button. It can go all the way up to your rib cage, because some women have many, many, many fibroids. With a surgery where we make a cut on the belly, we can remove as many fibroids as possible at the time of surgery. Even if we remove all the fibroids that we see, 15% of women will have fibroids come back, usually after a year to 2 years. And oftentimes in those women, because they have so many fibroids and they're so prone to fibroids, oftentimes we end up doing a hysterectomy because of bleeding or bulk symptoms after 5 to 10 years. And that's usually after childbearing has been completed. We don't have to do a hysterectomy, but oftentimes those women are so symptomatic from their fibroids that they're requesting hysterectomy for their quality of life. Whenever we do a surgery that makes a cut through the belly, either up and down or below the by the bikini line, the recovery time is about 6 weeks. These surgeries have a high blood loss, which is why oftentimes we use those medications to bring up your blood level before the surgery to reduce that blood loss. And usually when we do surgery in this way and remove fibroids through an incision like this, women need to have a cesarean section to be able to deliver safely. Otherwise, there's a risk that the uterus could break open at the area where we remove the fibroid, and that can be life-threatening for both mom and baby. And that's what we're talking about here, which is risk of uterine rupture. If you were to labor. So that's why we recommend a C-section. We used to be able to do something called a laparoscopic myomectomy. So instead of a big cut low down by the bikini line or up and down below the belly button, we would just put in a little camera here and ports here and remove the fibroid that way, and use something called a morcellator to chop up the fibroid and then remove it through a little hole in your belly through a bag. Unfortunately, we're not able to do that anymore because it increases the risk of many complications. So laparoscopic myomectomies are discouraged now if you use a morcellator. Sometimes doctors may talk to you about doing a laparoscopic myomectomy, but then they might make a little mini incision on the belly, so only about 4 centimeters, to remove the fibroid that way. That's still possible, but we don't use morcellators anymore, which is why we've returned to doing the abdominal myomectomy. And now, at the beginning of the presentation, we said that the type of fibroid that really impacts pregnancy and also really impacts bleeding are these fibroids that touch the lining of the uterus here, because this is where the pregnancy would implant on the lining of the uterus, and this is where baby would grow and develop. And this fibroid in this location really affects the ability for that to happen. So for women who have submucosal fibroids, who are having difficulty getting pregnant, we oftentimes recommend removing those fibroids. The way that we do that is called hysteroscopy. You're put to sleep, it's surgery. We put a little camera with a wire loop or a little sort of Pac-Man device at the end of it inside the uterus. We fill the uterus with saline. We're able to look inside the uterus and see these fibroids, and we're able to use this little wire loop to shave this fibroid off so that it's flush with the lining of the uterus. We can't take it all out because that's not safe. We don't want to make a hole in the uterus. So we just make it flush with the lining of the uterus. And by doing that, women's bleeding improves significantly, and the chance that they're able to conceive also goes up significantly. This is day surgery. So you go into the hospital in the morning, you leave later on that afternoon. By having this type of surgery, you don't need to have a cesarean section. You can deliver normally. So In summary, we know that fibroids can impact fertility. Overall, it's a cause for about 2 to 3% of infertility in women. Amongst African women, that number is probably much higher because we have many, many more fibroids compared to non-African women. Submucosal fibroids, those touching the lining of the uterus, have the biggest impact on fertility and heavy bleeding. Removing those submucosal fibroids improves fertility. We're able to do that hysteroscopically, so looking inside the uterus, and that still allows us to deliver vaginally if we choose. Intramural fibroids, so those fibroids in the wall of the uterus, have a smaller impact on fertility, but do contribute to bleeding and bulk symptoms. And those can be removed through abdominal myomectomies. They have less of an impact on fertility, and medical management provides some improvement in symptoms, but it's not a primary treatment for fertility. So thank you very much. I'm happy to take any questions.
Thank you, Dr. Jumah. Thank you so much. So we'll move the presentation along.
Thank you. Thank you very much, Dr. Naana Afua Jumah. That was quite an insightful time, a lot of information. We're so grateful for the wealth of knowledge. And on behalf of all the women, we say thank you so much. We really appreciate it.
Oh, Joy, I think you're on mute.
My apologies. So I said, first, thank you so much, Dr. Naana Jumah, for the wealth of knowledge, for the insightful information, quite helpful to every one of us. And we are indeed very grateful. We appreciate the information. And I want to say that we have, I think, 1 or 2 questions in the chat. If you have a moment with us to answer the question, we'll be very happy. So can I just go ahead?
Yes, please.
Thank you. So we have a question from one of our sisters. She said, what could be the cause of severe pain during menstruation for a 25-year-old lady, and what is the remedy? So there are 2 questions here. The cause of the severe pain and the remedy. Thank you.
Yeah, so that's a difficult question. So there can be lots of reasons why a young woman can have pain during menstruation. Usually that's something called endometriosis, which is a different condition that can also affect fertility. And that's where that lining of the uterus grows on the outside of the uterus, on the tubes, on the ovaries. And that can cause severe pain. So definitely if that's happening, I'd recommend seeing your primary care provider, family doctor, nurse practitioner, and considering getting a referral to a gynecologist. Sometimes we start women who have that on medications to manage that pain. We would usually also want to get an ultrasound to understand exactly what's happening to make sure that that is the diagnosis. So oftentimes that's the cause. Sometimes you can have ovarian cysts or other causes, and sometimes it's not related to the uterus or cervix or tubes or ovaries either. It could be the bladder, which is in that same area, or the bowels that are in that same area. So really you definitely want to be checked out by your primary care provider. For the gynecologic causes, so the causes that are from the uterus, cervix, tubes, or ovaries, endometriosis is the one that oftentimes is responsible for causing pain during periods.
Thank you very much for the answer. We're grateful. I have another question here as well from one of our sisters. She said, is it possible for fibroids to be removed during cesarean section for after childbirth? Is it possible?
Yes, and you know what? I had a slide on that and I took it out. I put it at the very end. Okay. So that is something called cesarean myomectomy. So removing the fibroids at the time of C-section. It is possible. Typically, we don't recommend doing it in Canada anyway, unless that fibroid is preventing you from being able to close the uterus after a C-section, or it's causing a lot of bleeding. I know that in Ghana, where I'm from, there has been a move back towards doing cesarean myomectomies, and that may be the same in other places in Africa, because women often can't afford to do a second surgery. But here, typically, we would recommend having your baby and then removing the fibroids at another time, just because the risk of bleeding is so high during pregnancy that it's safer to do it, 6 months, a year after pregnancy has been completed.
Okay. Thank you so much for that insight. So we also have another question here for you, Dr. Nana. It says, how can bilateral tuber blockage be removed?
So really the only way to deal with that is surgery if you're trying to get pregnant. And usually that's done laparoscopically. So that picture that I showed where you have the little cameras that we put inside the belly, and then we would remove the tubes and then take them out of the belly in a little bag. If you do that, you're not able to get pregnant on your own. You would need to go through in vitro fertilization, because you need those tubes to pass the egg into the tube and the fertilized egg into the tube into the uterus to get pregnant. Depending where you live in Canada, that is sometimes covered. So in Ontario, that's covered by OHIP for one round of in vitro fertilization or IVF. I know there are women here from all across Canada, which is absolutely amazing. I'm not sure what that coverage is like in other parts of the country.
Thank you very much. With respect to the question on painful menstruation, so I still have another question here. One of our sisters is asking, what about if an ultrasound has been done on the uterus and there's nothing wrong, but the pain still persists? What can be done?
Yeah, so like I said, sometimes we see that with endometriosis, but I'd really encourage you to see your family doctor, get a referral to a gynecologist, because there are medications that we can use that improve pain with menstruation. And there's a number of different ones, and medications are the most beneficial. We don't recommend surgery if it's endometriosis unless there's something else going on. And it sounds like if the ultrasound is normal, there isn't. So it's really important to follow up with your family doctor and request a referral to a gynecologist.
Okay, thank you so much. The next question is this, it's in twofold. It says, can a woman who has reached menopause have fibroid? And the other fold is, does fibroid disappear when a woman reaches menopause?
Yes, excellent questions. So, yes, so we oftentimes fibroids develop just as we age. They aren't cancer, they don't turn into cancer. They're just the normal muscle cells in the uterus, because the uterus is one large muscle, and we know that when we have contractions to deliver our babies. But some of those muscle cells will just start to grow and form a ball, like a tennis ball, like a golf ball, just like that. And they stay with us for life. After menopause, when we go through menopause, our hormone production of estrogen and progesterone stop. And so those hormones, like I said, they're those balls of muscles, and their growth is regulated by hormones. So when the hormones go away after menopause, those fibroids stop growing. And over time, the body will start to resorb them. They don't never go away entirely, but they do become smaller over time.
Okay, thank you so much. And we have another question here. I believe everyone is concerned. Why is fibroid more prevalent among African women?
You know what? It's a good question. I don't think we have an answer to that question, but we do see it definitely among African women. I think West African women more so than East African women. I don't have as much experience with Southern African women, but it is definitely more prevalent amongst us. We see in Asia as well that there are certain groups that have higher prevalence of fibroids. So Filipino women have a lot of fibroids. A lot of Chinese women have a lot of fibroids. And it's not clear why that's the case. I think it's just something that we have, but I haven't seen any good studies saying exactly what it is that makes us have more fibroids. Oh, I think you're on mute again, Joy.
So does fibroid run in family line, like from mother to daughter and things like that?
Yes, it does. So definitely if your mother has fibroids or female relatives have fibroids, you're more likely to have fibroids. The thing that can change that is if you have babies when you're really young, and I'm not saying that you should do that just to prevent fibroids, but if you have babies when you're really young, you may have very tiny fibroids, like the size of a grain of rice. And after delivery, when that uterus really contracts, the blood supply to those little fibroids that are the size of a grain of rice or a piece of sand gets cut off. And then those fibroids die and don't grow. So that as you get older, those fibroids don't have a chance to grow. Whereas if you have children later in life, when those fibroids are already grown and they're the size of a pea or the size of a plum or the size of a mango, then they will continue to grow. So we typically all have fibroids. They can be really small. If you're able to interrupt that blood supply to them early on, by having babies early in life is really the only way that we can do that, then it's less likely that those fibroids will grow as we age.
Well, thank you so much for all this useful information. And the last question I have is, will fibroid ever become cancerous? Will it ever?
No,
No? Okay.
they
Okay.
don't. But there are two different types of growth that can happen in the uterus. So fibroids are benign leiomyomas, and that's the technical term for them. Leiomyoma. That just means a smooth muscle cell tumor, but benign means not cancer. There is another type of growth that can happen in the uterus called a leiomyosarcoma. So leiomyoma, not cancer. Leiomyosarcoma is cancerous. So it can be difficult to tell which one is which just by looking at ultrasound. The only way that we can know is surgery. But leiomyosarcomas are cancer, and they start off as cancer and continue as cancer. Leiomyomas are fibroids. They start off as fibroids and continue as fibroids. They will never turn to cancer. So there are two separate ones. Leiomyosarcomas are very, very rare. And as far as I'm aware, the incidence of the cancerous type is not increased in African women compared to the overall population. They're very rare type of growth that can happen in the uterus across all populations.
Wow. Thank you so much, Dr. Naana Jumah. We are so grateful for this wealth of knowledge and insight. And I know every woman here today is very happy. We've gained a lot. We're so grateful for the teaching and all we have learned today. Thank you so much. We appreciate. And I want to say if there's any other question, can we reach you by email? Is it possible to send questions to you by email?
Yeah, you can send some. That would be okay.
Okay, thank you. So we'll be happy to have your email address so our women can reach you. Perhaps they may want one or two clarifications or, some concerns, and they want to be, directed properly. Thank you so much. We are happy to have you